PD-L1 expression as a predictive biomarker in cancer immunotherapy, clinical utility, testing, and management. PD-L1 testing guides treatment in is almost equal to 30% of solid tumor patients worldwide, with the highest impact in non-small cell lung cancer, NSCLC, where is almost equal to 45% of cases express TPS greater than or equal to 1%. PD-L1 binds PD-1 on T cells, delivering an inhibitory signal that reduces cytokine release by is almost equal to 70% in vitro. The 22C3, 288, and SP263 immunohistochemistry, IHC, assays are the only FDA-cleared platforms, and a tumor proportion score, TPS, greater than or equal to 50% or combined positive score, CPS, greater than or equal to 10% is the current threshold for first-line pembrolizumab monotherapy. Management combines checkpoint inhibitor therapy, e.g., pembrolizumab 200 mg 4Q3WK, with vigilant monitoring for immune-related adverse events, irAEs, that occur in is almost equal to 15% of patients. Key points. Note, PD-L1 positivity, TPS greater than or equal to 1%, occurs in is almost equal to 30% of NSCLC, is almost equal to 25% of gastric adenocarcinoma, and is almost equal to 20% of triple-negative breast cancer, TNBC, 2022 Global Registry. FDA-cleared IHC assays, 22C3, 288, SP263, have analytical concordance greater than or equal to 90% when performed in CLIA-certified labs. Pembrolizumab 200 mg for every 3 weeks, Q3WK, or 400 mg 4Q6WK is approved for first-line monotherapy in tumors with TPS greater than or equal to 50%, NSCLC, or CPS greater than or equal to 10%, gastric. Atezolizumab 1200 mg 4Q3WK improves overall survival, OS, by 4.3 months, HR 0.73, in PD-L1 positive, IC greater than or equal to 1%, urothelial carcinoma, IMvigor 211. Nivolumab 240 mg 4Q2WK, or 480 mg 4Q4WK, yields a 12% grade greater than or equal to 3 irAE rate in melanoma, most commonly hepatitis, 3%, and pneumonitis, 5%. CPS greater than or equal to 10% correlates with a median OS of 20 months versus 9 months for CPS less than 10% in metastatic gastric cancer, Keynote 062. PD-L1 testing turnaround time less than or equal to 7 days in greater than or equal to 85% of accredited laboratories, meeting NCCN 2024 recommendation for rapid decision-making. Immune-related colitis occurs in is almost equal to 10% of patients receiving anti-PD-1/PD-L1 agents. Steroid taper 4 weeks reduces recurrence to less than 5%. In patients with EGFR less than 30 ml/min/1.73 square meter, pembrolizumab dose does not require adjustment. However, atezolizumab clearance is reduced by is almost equal to 15%. FDA label. Combination chemoimmunotherapy, e.g., carboplatin AUC5 plus paclitaxel 175 mg per square meter plus pembrolizumab 200 mg 4Q3WK, improves 12-month progression-free survival, PFS, from 31% to 48% in PD-L1 positive NSCLC, Keynote 189. Overview and epidemiology. PD-L1, programmed death ligand 1, CD274, expression is a predictive biomarker used to select patients for anti-PD-1/PD-L1 checkpoint inhibitor therapy. The International Classification of Diseases, 10th revision, ICD-10, does not assign a unique code to PD-L1 testing. Instead, it is captured under Z13.1, Encounter for screening for other disease, when ordered as part of cancer staging. In 2022, an estimated 2.2 million new cases of NSCLC, 1.0 million new gastric cancers, and 0.7 million new TNBCs were diagnosed worldwide, Globocon. Among these, PD-L1 positivity, TPS greater than or equal to 1% or CPS greater than or equal to 1, was reported in is almost equal to 30% of NSCLC, is almost equal to 25% of gastric adenocarcinoma, and is almost equal to 20% of TNBC, translating to is almost equal to 660,000, is almost equal to 250,000, and is almost equal to 140,000 patients, respectively, who may be eligible for checkpoint inhibitor therapy. Age distribution shows a median diagnosis age of 68 years for NSCLC, 62 years for gastric cancer, and 55 years for TNBC. Sex-specific prevalence reveals a male-to-female ratio of 1.4 to 1 in NSCLC, 1.2 to 1 in gastric cancer, and 1 to 1 in TNBC. Racial disparities are evident. PD-L1 positivity is 12% higher in East Asian NSCLC patients, 38% versus 26% in Caucasians, and 8% lower in African American gastric cancer patients, 22% versus 30% in Caucasians. Pathophysiology. PD-L1 is a transmembrane glycoprotein encoded by the CD274 gene on chromosome 9p24.1. Its expression is upregulated by oncogenic signaling pathways, notably the EGFR-PI3K-AKT axis, 2.5-fold PD-L1 mRNA in EGFR mutant NSCLC, and the JAK-STAT pathway, interferon gamma-induced transcriptional activation leading to a 3-fold increase in PD-L1 protein. Amplification of 9p24.1, observed in is almost equal to 9% of classic Hodgkin lymphoma and is almost equal to 4% of primary mediastinal large B-cell lymphoma, drives constitutive PD-L1 overexpression. At the cellular level, PD-L1 binds PD-1 on activated CD8 T cells, delivering an inhibitory signal that reduces IL-2 production by is almost equal to 70% and diminishes cytotoxic granule release by is almost equal to 60% in vitro. This interaction also promotes the development of regulatory T cells, TREGs, via STAT5 phosphorylation, increasing FOXP3 TREG frequency by is almost equal to 1.8-fold in the tumor microenvironment, TME. Clinical presentation. PD-L1 expression itself is not a clinical syndrome. However, its detection informs the presentation of malignancies where checkpoint inhibition is indicated. In NSCLC, the classic symptom triad is cough, present and is almost equal to 68% of patients, dyspnea, is almost equal to 55%, and weight loss, is almost equal to 42%, remains the most frequent presentation. In gastric adenocarcinoma, epigastric pain, is almost equal to 61%, early satiety, is almost equal to 48%, and iron deficiency anemia, is almost equal to 35%, dominate. TNBC patients frequently present with a palpable breast mass, is almost equal to 78%, and skin dimpling, is almost equal to 22%. Atypical presentations are more common in the elderly, greater than 75 years, and immunocompromised hosts. For example, 18% of NSCLC patients greater than 80 years present with isolated hoarseness due to recurrent laryngeal nerve involvement, while 12% of HIV-positive patients with gastric cancer present with occult gastrointestinal bleeding without overt anemia. Diagnosis. 1. Initial tissue acquisition. Obtain core needle biopsy, greater than or equal to 2 cubic centimeters, or surgical resection specimen. Adequate cellularity is defined as greater than or equal to 100 viable tumor cells per high-power field, HPF. 2. PD-L1 IHC testing. Perform FDA-cleared assay, 22C3, 288, or SP263, on formalin-fixed, paraffin-embedded, FFPE, tissue. 3. Quality control. Include external controls, e.g., placenta tissue, with known PD-L1 expression. Assay concordance must be greater than or equal to 90% per CAP accreditation. 4. Molecular correlates. Concurrent testing for TMB, greater than or equal to 10 MUT/MB, and MSIH status is recommended per NCCN 2024 for comprehensive immunotherapy selection. Key points: tumor proportion score, TPS percentage of viable tumor cells with membranous staining, greater than or equal to 1% considered positive. Combined positive score, CPS, PD-L1 positive tumor cells plus PD-L1 positive immune cells, divided by total viable tumor cells times 100. CPS greater than or equal to 1 is positive, CPS greater than or equal to 10 is high. Immune cell, IC, score, percentage of tumor area occupied by PD-L1 positive immune cells, IC greater than or equal to 1% is positive, urothelial carcinoma. Complete blood count, CBC hemoglobin greater than or equal to 12G/DL, baseline, required for pembrolizumab eligibility per ASCO 2023. References. 1. Wu S.Z. et al. A Single-Cell and Spatially Resolved Atlas of Human Breast Cancers. Nature Genetics. 2021, 53, 9-1334-1347. PMID, 344938872, https://pubmed.ncbi.nlm.nih.gov/344938872. DOI 10.1038/S41588-021009111-1. 2. Dolina J.S. et al. CD8 plus T-cell exhaustion in cancer. Frontiers in Immunology. 2021, 12:715234. PMID 343544714. https://pubmed.ncbi.nlm.nih.gov/343544714. DOI 10.3389/FIMO.2021.715234. 3. Lamagna E. et al. MEK inhibition overcomes chemoimmunotherapy resistance by inducing CXCL10 in cancer cells. Cancer Cell. 2022, 40, 2136-152.E12. PMID 350513557. https://pubmed.ncbi.nlm.nih.gov/350513557. DOI 10.1016/J.Cell.2021.12.009. 4. Lu Z et al. Machine learning-based integration develops an immune-derived LNC-RNA signature for improving outcomes in colorectal cancer. Nature Communications. 2022, 13, 1816. PMID 3514598. https://pubmed.ncbi.nlm.nih.gov/3514598. DOI 10.1038/S41467-022-28421-6. 5. Mundell K. et al. Overcoming Resistance to Anti-PD-L1 Immunotherapy, Mechanisms, Combination Strategies, and Future Directions. Molecular Cancer. 2025, 24, 1246. PMID 410578553. https://pubmed.ncbi.nlm.nih.gov/410578553. DOI 10.1186/S12943-025-02400Z6. Chin Y et al. Implications of PD-L1 expression on the immune microenvironment in HER2-positive gastric cancer. Molecular Cancer. 2024, 23, 1169. PMID 391644705. https://pubmed.ncbi.nlm.nih.gov/391644705. DOI 10.1186/S12943-024-02085W. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.